I am VASI, an AI agent designed by Dr. Mohammed Amr El-Farak with one core purpose, to help you excel in your MRCS exams. Today, we're going to master the Abdominal Examination OSE station. My goal is to help you turn this challenging task into a performance you can be truly confident in. Examine this patient's abdomen. That's it. That's the prompt. Just a few simple words that kick off one of the most high-pressure stations you're going to face. But don't worry, we're going to deconstruct this challenge step by step so you can walk into that room and deliver a confident, systematic, and flawless performance. And here's how we're going to do it. We will follow this structured 6-part approach. This sequence is designed to mirror the exact flow you should perform in the exam, from the moment you walk in to the final questions. So let's dive right into section 1. First up, setting the stage. You know, those first few moments are absolutely crucial. This is where you establish your professionalism, you set the tone for the entire station, and you show the examiner, right from the get-go, that you are in complete control. It all starts with these 4 non-negotiable first steps. First, introduce yourself. Then, ask for permission. Next, position the patient. Make sure they're lying flat. And finally, expose the abdomen properly. We're talking from the zippy sternum right down to the pubic symphysis. And a key point here, always maintain the patient's dignity by keeping the groin covered. It's a huge marker of professionalism. Now, before you even think about touching the patient, I want you to stop. Take a step back. To the end of the bed. Seriously. From here, you can gather a wealth of information. Just look. Is the patient comfortable, or are they wincing in pain? Do they appear well-nourished, or maybe a bit cachectic? Are there any obvious clues like jaundice, or attachments like drains or stoma bags? This initial observation is critical. All right, let's move on. Remember, the abdomen doesn't exist in a vacuum. A really skilled clinician, and that's what you are, knows that crucial diagnostic clues are often found far from the abdomen itself. The examiners are expecting you to find them in the hands, the face, and on the trunk. Let's start with the hands. Think of them as a billboard for systemic disease. You need to be actively looking for nail changes. See any clubbing? You should be thinking about IBD or cirrhosis. What about leukonychia? That could be a sign of liver disease. And you absolutely have to check for a liver flap for asterexis. That coarse, flapping tremor is a classic, can't-miss sign of decompensated liver disease. Okay, from the hands we continue our scan upwards. Check the eyes for pallor in the conjunctiva or for jaundice. Look in the mouth for ulcers suggestive of IBD. On the trunk, you're hunting for spider navy, gynecomastia, or maybe scratch marks. And finally, and this is critical, don't forget to palpate the left supraclavicular fossa. Finding Virchow's node there is a major finding, a classic sign of metastatic gastric cancer. So, we've done our general survey, we've gathered all those external clues, now it's time to focus on the abdomen itself. And to make sure you don't miss a single thing, we are going to follow a strict, memorable 4-part sequence. You need to burn this into your brain. Here it is, your abdominal exam mantra. Inspect, auscultate, percuss, and palpate. Let me repeat. Inspect, then auscultate, then percuss and palpate. That order is absolutely crucial. You have to listen with your stethoscope before you start poking and prodding because palpating the abdomen can artificially alter the bowel sounds. Let's break down each step. Inspection isn't just a quick glance. You have to be an active observer. Get down to the patient's level. Look for scars, any distension, skin changes like bruising, or the dilated veins of a caput medusa. Then, and this is a pro tip a lot of people forget, ask the patient to cough or lift their head off the bed. This simple move increases intra-abdominal pressure and can make hidden hernias just pop right out. Okay, as we move to palpation, I want to pause on this single most important principle. Always, always look at the patient's face. Your hands are feeling for signs, yes, but their face is telling you about tenderness. A slight wince or a grimace provides more accurate feedback than any verbal response they could ever give you. So, we always begin with superficial palpation. Use the flat of your fingers and gently assess all 9 quadrants. And where do you start? You start in the area furthest away from any stated pain. You're feeling for tenderness, guarding, and rigidity, all signs of peritonism. Only after this do you move on to deep palpation, where you'll methodically search for masses and assess the organs. With our general palpation complete, we now focus our techniques. It's time to get specific and assess the size, shape, and texture of the major abdominal organs. To palpate the liver, you have to start low, way down in the right iliac fossa. Why? To make sure you don't miss a massively enlarged liver. If you start too high, you'll be on top of it and won't feel the edge. So start low, ask the patient to take deep breaths, and as they do, gently press upwards and inwards. You're trying to catch the liver edge with your fingertips as it descends on inspiration. Now, if an organ is palpable, you have to describe it. For the liver, note its size in centimeters below the costal margin, its texture, is it soft, firm, nodular, and its edge, is it smooth or irregular? A hard, irregular edge should make you think of metastases. For the spleen, you'll use a similar technique, moving diagonally from the right iliac fossa. For the kidneys, you use that bimanual balloting technique. And don't forget the aorta. Palpate deeply for an expansile pulsatile mass. To complete our assessment, we bring it home with percussion and our already performed auscultation. Percussion helps us to find the liver's upper border, detect an enlarged spleen or bladder, and it's essential for demonstrating shifting dullness in ascites. Then, with your stethoscope, you're not only listening for bowel sounds, but also for vascular bruits over the liver, aorta, and renal arteries, which could indicate turbulence. All right, let's switch gears and apply our systematic approach to two special cases that frequently appear in OSCEs: hernias and stomas. Success here requires demonstrating very specific examination techniques. Differentiating an inguinal hernia is a classic challenge. So after reducing the hernia, you place your fingers over the deep inguinal ring that's midway between the ASIS and the pubic tubercle. Ask the patient to cough. If the hernia stays reduced, it's indirect. If it bulges out medial to your fingers, it's direct. Now, while it's not perfectly accurate clinically, demonstrating this technique shows the examiner you understand the anatomy of the inguinal canal. Now, what's great is that stoma identification can be pretty simple if you just remember three key features. An ileostomy is typically in the right iliac fossa, it's spouted to protect the skin from enzymatic output, and its contents are liquid. A colostomy, on the other hand, is often in the left iliac fossa, it's flush with the skin, and it has solid fecal content. The physical examination is complete, but the station isn't over. You might think you're done, but you're not. Your conclusion is just as important as your introduction. To show a complete and thorough approach, you have to verbalize the steps you would take to finish. State clearly to the examiner, to complete my examination, I would like to examine the hernial orifices, the external genitalia, and perform a digital rectal examination. Adding that you'd check lower limbs for edema and do a urine dipstick shows you're thinking systemically. Then turn to the patient, cover them up, and thank them. Mastering the physical maneuvers is half the battle. The other half is anticipating the examiner's questions. Why does this matter? Because your answers demonstrate the clinical reasoning that underpins your technical performance. Be prepared for these topics, because this is what separates a pass from a distinction. Remember, the perfect examination isn't just a sequence of steps. It's a process of generating and testing hypotheses in real time. That is the skill you're truly there to demonstrate.